And we're back. We have David Hohenschurz-Schmidt. Welcome on, David. This is your first time. For people that aren't familiar with you, and since you haven't been on before, can you just give people kind of a background on yourself and currently what your roles are?
Sure. Hi, Chris. Hi, everyone. Thanks for inviting me. It's a real pleasure to be on this podcast series. It's a very curated list of speakers. So I'm thrilled to be here. My background, I guess, starts off as a clinician, a manuotherapist, specifically an osteopath, which is a manuotherapy profession in Europe. Um, I'm originally from Germany, but went to the UK about 14 years ago now to train as an osteopath, and then was involved in clinical practice, but also at a teaching institution for a few years in Germany, and then came back to London a few years later to do a master's in neuroscience. And I had enjoyed research and critical thinking, project planning, these sort of things also during my first degree, but it was really that master's where I caught fire for academic work and research. And through that, I then got into a PhD that was focused on clinical trial methods in non-pharmacological interventions. So really asking how to make trials in my particular field, but also in psychological interventions or physiotherapy better. And the big question there was, in a drug trial, you use a sugar pill as a placebo to account for placebo effects in that classical placebo-controlled, randomized controlled trial. But what's the equivalent or the best solution for that in trials of physical intervention, psychological therapies, etc.?
Yeah, well, you mentioned it, placebo. So I found out about you through just some recent publications of yours, a systematic review, and then a few others where you were the primary author on placebo and nocebo. And that's what we're going to talk about today, and how it influences outcomes and whether or not we should utilize it to our advantage and what actually are these things. So let's start off kind of with just definitions. What is a placebo and what are placebo effects? And then flipping that to same question for nocebo.
Yeah. I think we need to distinguish placebo as a substance or as a thing, and placebo effects, which are physiological or clinical phenomenon. Um, I think if I just hark back to the clinical research project, anyone who's ever read any physiotherapy or exercise trials will have come across these interventions that seem to that seek to convey the meaning of a treatment to patients, but actually aren't. Yeah, so they're called placebo controls or sham interventions or dummy treatment. So the aim there really is to make patients believe that they are receiving a treatment, but actually not give them the treatment. And the reason we're doing this is because at some point in the last century, people realized that just from believing that you're getting a treatment, people tend to get better. And that's what we then call the placebo effect, which the sort of more stringent and scientific definition is that it's a healthcare or health benefit as a result of placebo mechanisms, which are positive expectations or positive learning or conditioning that can be triggered by receiving a placebo, so one of those inert substances or actions, but they can also be triggered by something else. And that's probably something we're going to talk about later on, how to harness these placebo mechanisms. Yeah, and the nocebo effect then is basically the evil twin, same underlying mechanisms, but negative expectations and negative learning that can result in measurable physiological or clinical changes as a result of being administered a placebo or any other treatment that then triggers these negative learning and expectation effects.
To the kind of statement you made of sham interventions, that seems easier in certain types of medical care. For example, with different types of medications, being able to sham or placebo medication for studying. How are these placebo or sham interventions, how do they actually occur in research? And how do people create that when you're interacting with patients as a physiotherapist?
Yeah, that's the basis of the whole problem, because how people approach that or go about solving this challenge in complex intervention trials is very heterogeneous. So you might have come across trials of exercises that use a switched off ultrasound device to produce the belief in half their participants that they're receiving an effective and active intervention, but actually it's quite a good way of doing something to people that looks like a real treatment, but actually you've switched it off quite literally. And then if you've read any spine manipulation literature, they might go to longer lengths of trying to simulate the treatment, do something that's a bit more similar than the treatment, but misses a particular component that they want to study. So they might put people into a wind up or into a certain position, but then not go through with a thrust, or go through with a thrust but in a different direction or with a different force. And these are extreme ends of the spectrum. In one scenario, you've had that ultrasound device that's very, very different across a whole list of features that you could look at it. Looks very different, feels very different, and is very distinct to an exercise intervention in that example. And the other one is one of a probably higher fidelity or more similar control intervention that comes with other challenges. For example, teasing out which particular treatment component you want to leave out. And that was the challenge when I started the PhD, that recognition that at the moment we certainly don't have a standardization for this. So in the project, we set about systematically studying this and also asking whether that's a problem at all. It might be that both approaches lead to the same expectations, and then that ideally isn't an issue, because remember, you're comparing the treatment to that control intervention. So these control interventions are important. They make up half your clinical study, and they are the basis of what you compare your treatment to. But actually, we found that it does matter, for example, how similar or dissimilar those control interventions are to your treatment. So that influences the difference between the control intervention that you see and the treatment effect that you see. And that means that there was a need to standardize that, and that's part of the projects that we then did afterwards, which was a big consensus statement on how to go about conceptually designing and testing those control interventions, delivering them in clinical trials, but also thinking about quality assurance and how to write those interventions up in your trial report so that people later on can use your research and compare it to others.
And just reiterating the necessity or the value of these control interventions or groups is to make sure that the true intervention is providing an actual effect outside of these just contextual or placebo-like effects. Is that fair to say?
Yeah, exactly. That's in the pharmacological development process. That's the benchmark of an active treatment, whether or not it has effects beyond the effects of a placebo. So the belief of getting a treatment and not knowing for certain whether it's a treatment or not. We don't have these kind of regulations in non-pharmacological therapies usually, but you could probably argue that it's still at least a valid scientific and potentially an ethical question to answer that, whether the treatment that you have either developed afresh or that you've been delivering for decades in your clinic has an effect beyond producing positive expectation and learning in your patients.
And can you touch on, in the clinical context, what are some of these examples of what a placebo-like effect could be, or on the opposite or flip side, what nocebo-like effects could be, or how they could occur?
Yeah. It's really anything that can trigger positive expectations or positive learning. So the most obvious example is probably that you're telling someone they're going to get better or they're going to get worse in the case of a nocebo effect. That might be partly your reasonable clinical prognosis, but what you're also doing is you're changing expectations. In that case, with verbal communication, you can then see how you could create or change expectations also with nonverbal communication, so how you respond, for example, to seeing someone or listening to someone's problem, whether you reinforce that and say, oh, that's really bad, or whether you absorb the information, show empathy, but without overemphasizing the negative aspects of that. Conversely, the positive side of things. But then, any characteristic of a treatment, and that's important in a clinical context, even an active treatment, so one that has effects beyond the placebo, beyond placebo effects, has many other features that have the potential to influence positive or expectations in learning. So that might be how fancy your treatment looks, the reputation of the treatment and the clinician, the price people pay for it, and the context in which it's delivered. So the clinical setting, for example. And I guess that gets us to the topic of contextual factors, which is another phrase that's often used in that context. And I think he was a guest on your podcast as well. Chad Cook led a consensus process that they published last year trying to define contextual factors. And they do say it's these elements of treatments that can stimulate expectation and learning effects. And they split them up into patient characteristics, provider characteristics, the interaction between them, the setting, and probably a few others that I forgot about. But that shows you that it's not, if you're thinking, for example, of the interaction between a practitioner and a patient, that's not necessarily just something that stimulates expectations. It can have other effects as well. So whether or not you trust or like your practitioner might make you more or less likely to actually go through with the recommendations that they gave you or follow through with the treatment. And that's partly expectations, but it's partly behavioral effect that you have there. And that's one of the challenges when you talk about contextual factors. They aren't necessarily all just addressing expectations. They are also things that we quite rightly use in clinical practice, like education, good communication, professionalism, something people would call psychological skills as well, like motivational interviewing, that have effects probably on expectations, but also other mechanisms.
And with physiotherapy, chiropractic, osteopathy, a lot of the interaction and the benefit seems to be coming from these contextual factors and potentially not from really strong, potent stimulus from the actual intervention itself. Is that fair to say with a lot of different interventions? A lot of these beliefs, values, expectations from these contextual factors are providing a really substantial input into people's kind of outcomes or their perception of their body, that should be taken really seriously as a healthcare provider to really utilize these contextual factors?
Yeah, there are probably two questions there, and I won't be tempted to list the interventions of which I think work only as placebo effect or through placebo effects, and those that have effects beyond that. I don't think that's the relevant aspect that you're trying to get at. I think the important thing, as you said, is you can't separate effects on expectations and learning, or these placebo effects, from the rest of what you've been taught in school is the important part of the treatment. That's probably one of the discrepancies that we see a little bit in some of the more traditional musculoskeletal training programs, that you have a big focus on the biological mechanisms or the biomechanics, and less so on the other things that might professionally enhance those contextual factors or use them, put them to good use. So yes, I think the clinical takeaway from that is that you can never ignore it. They aren't something that you can leave out for a day. It's a bit like you're always interested in maintaining or establishing a trusting and positive therapeutic alliance with your patients. And similarly, considering expectations, what the expectations are that patients have when they come to you, what their previous experiences are that might influence the expectations that they form when your treatment is being applied or when they meet you, but also things that you didn't think would necessarily influence their expectations. For example, how you communicate your diagnosis, whether that might resonate with them differently to what you think it will. So, as an example, in my world of osteopathy, the term dysfunction or somatic dysfunction is used as a diagnostic term by many practitioners, and that sounds, after 3 or 4 years of training, sounds like a benign thing to you as a practitioner. But if you've never heard the term, or if you tend to be a little bit anxious about what's wrong with your body, and someone tells you, well, you've got a few dysfunctions there in your spine, and you're not a medical person as a patient necessarily, that might create negative expectations. Other terms would be, a hip discrepancy or limited movement, wear and tear, even things that we think sound relatively benign, but we don't really know how they resonate with a patient. And we wrote a paper on that in musculoskeletal science and practice, where we really invite people, clinicians, to reflect on what they say and what they do that might produce negative effects, negative learning, but also other undesirable side effects, other undesirable effects, like making people more dependent on you, thinking they need you to fix them, for example. It's not necessarily a placebo or nocebo effect, but it's certainly not a desirable or ethical outcome of your interaction with a patient.
Yeah, in that paper, you all provided examples in different areas or different professions within physio, osteopathy, chiropractic, of some of these, common and outdated framing of messages or narratives or ways of treating. I'm going to dive into a few, and maybe we can riff off of that. But for example, with physiotherapy, you all mentioned this excessive attention to tissue modification induced through treatment. And you use kind of this quote or example of the massage will normalize your fascia and trigger points. Another example in PT or physio is this overemphasis on teaching quote unquote proper static and active postures, and common kind of cues and corrections that physios will give to patients on avoiding slouched positions or keeping your back straight at all times. And then lastly, for physio, this overuse of low value therapies, which we've had Josh Sadro on to discuss this, but electrotherapy and ultrasound and things that are largely not recommended within big international guidelines. And all of these not being helpful from a quality of care standpoint, but also, like you said, the messaging and the input in how patients are viewing their body. And it's a very fragile mindset and narrative with a lot of these, and they're just not really correct. So that's from a physio standpoint, examples you all provided. Do you have any thoughts or things you want to add there before some of these other examples?
No, I think you've put that really, really well. We're basically trying to make the argument that there's something inherent in our profession and our professional identity that might mean we have to be a bit careful about producing some of those negative expectations or undesirable effects. These were really good examples. The posture is such a good one, where we think it's good advice, it's benign advice to tell someone to not slouch. And then we all get patients who've seen practitioners before who have communicated the importance of posture. And one of the first things, just last week, a patient said to me was, I've worked so hard with osteopathy on my posture. Now I'm sitting upright. And that was one of the main takeaways they've ever had from years of seeing an osteopath. And there was nothing around the importance of being active and engaging in regular physical activity, which I would have hoped they had gotten along the way as well somewhere. That yeah, it's just a question of emphasis as well. Where do you want to place your emphasis in your clinical encounter?
To that point, I'm curious to hear your thoughts on this, but the current clinic that I'm in, there's a spectrum of I would say physio's narratives and beliefs around certain things like posture or the utility of changing it or bringing it to someone's attention and how much it influences their symptoms. But my communication and education with a patient is around there being a lot of options and really no correct posture. And maybe this position is irritable at this point and we adjust, but long term, there's so much variability of how we move and what you want to do with your life. And on the flip side, there's other providers that are very strict and dogmatic about certain things, but those patients really like the providers and they seem to be getting better and they enjoy coming in. And it's these very divergent kind of treatment styles, but to the contextual factors and these placebo effects, a lot of these musculoskeletal conditions, because they have a positive natural history or they have these regressions to the mean, that even if the narratives are poor, if you like your provider and you trust them, there can still be positive outcomes. So is that also hard because we're not dealing with patients where it's a do or die and we're not getting immediate negative feedback if we're providing maybe not the most evidence-based therapies or narratives, because there's so much contextual effects and it's so much of it is on these provider clinician interaction. How do we just kind of like reconcile that, where I see a lot of patients that are hearing completely opposite things, but they're leaving the clinic happy, they're being discharged, but it's kind of not the best type of care or narratives. Do you have any thoughts there?
Yeah, there's your PhD project. You've touched on two huge conundrums. The first is patients come to you with a preformed belief. What's the harm in trying to change that belief and ruining that belief? Yeah, at best you're losing the patient because it doesn't. You don't attach there where they're at. You don't meet them where they're at, and maybe there's more of a research question whether you're actually doing harm by trying to change someone's mindset when it's not actively negative. And then the other thing is the element of patient satisfaction. And I know you've discussed that in one of the podcasts on education, I think, where there's just this very natural desire for black and white and straightforward answers, simple solutions. And probably a lot of people go to their osteopaths or physios, I know my dad does certainly, to get simple answers and a quick fix. And then telling someone that, no, actually, you've got a whole menu of choices that you need to decide now individually what you want to try. And then even then, I can't promise it's going to work. That doesn't necessarily lead to positive expectations. And it might, again, have other problems with, it's just not what people want necessarily. So that's a challenge that placebo effects and the science of placebo and communication skills in general does show us.
It's tough because the confident, straightforward, simple answer provider comes across as all of those things to the patient, and the clear messaging or the very straightforward narrative or prescription probably comes across to the patient as, this person's confident, they're in charge, I have more trust in the process, I'm going to follow through this plan. And with maybe some other clinicians that realize the uncertainty or the unknowns with a lot of why effects are occurring or why certain interventions are helpful, or the unknown of the long-term prognosis, all of these things that are super messy and probably should have a little bit more uncertainty around them. But that may come across to the patient as, this provider doesn't know what they're talking about or they're uncertain. How do we balance that, providing and instilling the confidence and utilizing some of those positive contextual factors and saying that this will be beneficial without essentially lying to a patient?
Yeah. I mean, with clinical experience, most clinicians probably wouldn't try and change a patient's mindset at the first visit, and would probably play along to a certain degree with pre-existing expectations and beliefs. It's just important, I think, in the first consultation to evaluate those and know where you are with regards to that and where the patient is. And and then you can start building a therapeutic relationship, and at that point, hopefully try and address the ones that you think are actually harmful in that particular person, or for that particular person, or that are in the way of something else that might be more beneficial. And then communicating uncertainty, again, is something we need to learn to do confidently, which is almost paradoxical and ironic, but can certainly be done. And then I'm not sure if the last part of your question was, how can we exploit some of the placebo effects? Is that what you're getting at?
Yeah, I think we can go into that of, is it ethical to exploit these effects, and is there a boundary or line there?
Yeah. So provocatively speaking, I'd argue there is a line of delivering treatments that we quite confidently know don't work beyond expectation effects. So in other words, that have been shown in high quality clinical trials to not work beyond a placebo. I do think we don't have to go all the way there. Well, there is also the option of telling patients, yeah, we don't think that works more than via expectations, which is what you call an open label placebo. That's certainly something very much explored at the moment, but is the other extreme. And I think there's a lot in between those ethical boundaries where we can communicate confidence and evaluate and then change expectations without having to run into ethical problems. So a good example is how much of your diagnosis you communicate and how you communicate it, how you frame a prognosis. The classic example is, a 20% risk versus an 80% benefit. But that's an extreme example. It's more around, within good within ethical boundaries, communicate a positive expectation, or use reassurance quite deliberately and quite strongly, as much as is realistic in that clinical scenario. So that's a good example. And then all the other things that we touched on earlier, those contextual factors that you can train and harness. So skills around communication and building good therapeutic relationships, psychologically informed practice, and using those skills to produce positive expectations as well. These are all certainly ethical ways of using placebo research in clinical practice.
To that one end of the extreme of not using therapies that, when they are measured against a true sham and there is no additional specific effects, what if a patient's asking for one of those interventions? How would you suggest, or how do you, when you've seen patients in these scenarios, discuss what those reasons are why you may not feel comfortable or think it's beneficial to provide that care? And a lot of times, off of that, the response or the answer for them may be, but I've had a good experience in the past, or it feels really good, why can't you just do it? Like, what are your thoughts with interacting in those scenarios where they're expecting or wanting those treatments, and how, as a provider, do you tactfully navigate that?
Mm-hmm. Yeah, I do certainly try to be open and transparent about that. So I would potentially say, yeah, I can do that, but I wouldn't play along with communicating all the models that come with, for example, craniosacral therapy, telling people that there's a particular rhythm that I can palpate, and I definitely try to not just rely on that particular method. Also explore why people want that and what they think it is actually doing. And then once you do that, often I found in the past, they aren't as wedded to that intervention as they maybe told the receptionist when they booked the appointment. They're actually quite open to a different approach. And even if you spend 10 minutes putting your hands on someone's head, you can still use that time in other ways to explore, for example, what else is going on in their life, and where you might address issues that you think are more relevant to them. So I wouldn't throw them out of my toolbox entirely, but I also wouldn't focus my entire clinical practice on those interventions, and I certainly don't advertise them.
Is there anything else around this topic more clinically from placebo, nocebo, these contextual factors that we haven't touched on that you think is worth discussing?
I think a fascinating aspect that you had in your list of questions that you sent me beforehand was around rituals. And it's definitely one of my favorite elements of placebo research. When we think about rituals, we tend to think about exotic, for example, shamanic rituals. The definition of a ritual is some repetitive actions, usually repetitive, that are clearly laden with some kind of meaning. They're clearly recognizable as not being part of the normal human repertoire of activities. And that shamanic experience shows you that often the meaning is one of healing. It can be one of harm. If you think of voodoo, it can be one of spirituality. And that's probably where in the West we see most obvious examples of rituals still being existent. But we don't have to go that far. We can look in normal human interactions, shaking hands, hugging people, stroking someone's knee when they've bumped their knee. But then clinical practice, I think, is also full of rituals. If you're thinking of a assessment in a physiotherapy clinic where you're going through certain movements, or a manuotherapist palpating you, usually with a really, really concentrated look on their face, conveying meaning that something here is happening, and that something means healing, and where that meaning then links to placebo effects is in the work of an anthropologist, I think originally, called Dan Merman, who studied healing rituals in various cultures, and called that the healing response at some point. And at a very similar time, placebo researchers started pointing out that it's really the perception of the participant, the person who receives the placebo, so whether they perceive that as being healingly meaningful, that drives then the measurable physiological clinical effects. So that's, I think, where rituals come in quite nicely, and where I find them fascinating to just maybe take this sort of Marsian perspective on your clinical practice and say, what am I doing here that's actually part of my treatment, but also very ritualistic. I find that interesting, just as a side note.
Yeah, and a lot of the maybe suspected diagnoses are coming through with a patient's subjective and their prior history and what they're describing. And a lot of objective testing isn't that inherently specific or special, and it may not change your plan of care or your thoughts about the diagnosis, but it has a really powerful effect on their perceptions of this initial evaluation, and you as a confident, competent provider, and maybe not an exaggerated clinical exam, but maybe something that is, thorough, like you mentioned, to show that you're diving into this and you're present and you're actively investigating, in a sense, even though as a provider, you may already have an idea of where to go from here. So yeah, it is this ritual that one helps you confirm and provide more information, but also just showing the patient that you're in the hands of a trusted provider and they know what they're doing.
Yeah, absolutely. I want to emphasize something else as well. We've been using physiotherapy and manuotherapies as an example here, but it's important to say that the use of placebos is really widespread also in normal medical clinical practice. There are loads of studies of clinicians prescribing things of which they're very aware won't have a particular effect on that patient, either to just do something, a bit like just show that you're at least looking carefully, you're at least providing, I don't know, a vitamin or an injection of some sort. But also because there is this very human desire to help and to do something, even if you may not have a tool that to work in that particular instance, and you do know that doing something is better than doing nothing in some instances, and you weigh up the harm versus the benefit in some cases. So I'm just re-emphasizing that it's not just these physical interventions where we're looking at placebo effects. And I've also had in the past sometimes the perception that when you talk about placebo effects, for example, in the context of osteopathy, that what you're really saying is that the whole thing doesn't work better than placebo effects. And I think some of that comes from that bad reputation that placebos got from them really being a nuisance in clinical trials. So they just don't have a good ring to them. I hope what we were able to discuss today was also that they are part and parcel of every clinical intervention, and they're actually potentially a positive thing that you definitely can't ignore it. You can really embrace it if you want to. So I think that's a more important takeaway than worrying about whether this or that intervention works beyond placebo effects. For a clinician, I think as a professional, we do have the responsibility to ask that question as well and to study it rigorously.
Yeah, sure. Anything else before we wrap up that you want to touch on, David?
No, that was fun. Thank you very much, Chris.
Yeah, of course. I will direct or we'll link a variety of your articles if people want to dive more into this. And we will call it there. Thanks again.
Thank you.